Well, good morning, everybody. We are running a little late because Carolyn and I were trying to solve a technical glitch. I cannot see Carolyn, nor can I hear her. And I now believe we are live. And I think what Carolyn's going to do is ask me the questions via text while she tries to reboot and get us connected here. So, Carolyn, would you send me the first question there, or try talking? But I don't think I'm going to be able to hear you, because I definitely cannot see you. Although I see you're connected to Restream. So let's see. We have a question coming from Carolyn. Or what I'll do is I'll see if I can get it through email. Okay. Here's the first question. Carolyn is texting me this question. Uterine fibroids, what causes them? If a woman has low hormones, does this cause uterine fibroids? Well, I don't know the exact cause of fibroids. One thing we know is that estrogen stimulates the uterus, and too much estrogen overstimulates the uterus. And what is too much estrogen? Well, the maximum amount of estrogen a woman has is when she is 20 years old, plus or minus a year or two. And from that moment on, it declines. So if she's in her 30s, when these fibroids tend to become prominent, or in her 40s, what she needs with the proper amount of estrogen is the proper amount of progesterone to balance, because progesterone quiets, progesterone calms. And when you have the proper estrogen and progesterone balance, then there's no overstimulation of the uterus. So what can commonly happen in the perimenopause is that a woman's progesterone can be declining faster and earlier than her estrogen does. So even though they both might start out at the absolute peak at age 20, this would be estrogen, this would be progesterone. The progesterone can be declining earlier and faster, leaving a predominance of estrogen stimulation, even though estrogen's at a lower level than it was when she was in her 20s. That overstimulation of the uterus is believed to be part of how a fibroid forms. And the moral of the story is, what happened to the progesterone? And for one thing, progesterone is secreted by the ovary in about 100 times more amount than estrogen is. Progesterone is a major ovarian hormone. And in order to secrete that much progesterone, the woman must ovulate. The progesterone factory that produces these prodigious amounts happens to be the cell that line the egg that ovulates each month. And if that egg ovulates, then those cells become progesterone factories. And for the second half of a woman's cycle after ovulation, robust amounts of progesterone are being produced. A woman can still have regular cycles and still produce a significant, robust amount of progesterone, but she may not be producing the optimal amount of progesterone, the amount needed to balance the stimulatory effects of estrogen, and that will cause a fibroid to grow. So what do you do about this? Why is progesterone declining earlier and deeper than estrogen? I don't know the answer to that, but that is a medical observation, and it occurs very commonly. And how does it show up? A woman who has regular symptomless or almost symptomless periods throughout her 20s and into her 30s, and into somewhere in her 30s, she starts getting uterine cramps, return of PMS, or some breast tenderness during the second half of her cycle. Ooh, that's the indicator that estrogen stimulation is no longer getting beautifully balanced by a robust amount of progesterone. And what's the remedy? Replenish progesterone. And this has been known for a long time. In the 80s. Dr. John Lee, a medical doctor, wrote about this and actually developed over-the-counter progesterone creams. And you can do a lot of good with them. They're not very strong. They're not prescription grade because they're over the counter. But for a woman in her 30s, she doesn't need that much to balance the estrogen. So whenever there's a return of cramps or PMS or some breast tenderness to a woman in her 30s, that's the signal for her to acquire some progesterone. Best case scenario, she links up with a healthcare provider who really understands treating women in menopause with compounded bioidentical hormones. That is the absolute best thing in the world to happen. And then you can dial it in with great accuracy. And yet, in lieu of that, just getting over-the-counter progesterone in 1.8%, which is 18 milligrams per milliliter, and applying some in the evening or before bedtime, you can balance. You should be applying it until you no longer get that PMS or cramps or breast tenderness. That'll be your signal that you're balancing the amount of stimulatory estrogen with that calming progesterone. So that, we feel, is one of the ways to prevent fibroids. Fibroids are not cancer. They can be a hassle. They can cause increased bleeding, but they are not cancer, and that's really good to know. But so their main problem is being a hassle. And again, moral of the story, be aware of this. And if you're getting PMS or cramps or breast tenderness that you didn't have, or any vaginal dryness that you didn't, well, not so much that you didn't have when you were in your 20s, get thee some progesterone and apply it liberally. It's so safe. You can take just tremendous amounts of progesterone and keep jacking up your dose to see if you can actually get rid of those uterine cramps, because that, when you do, that's the signal that estrogen is being balanced and you're not overstimulating that uterus, which can help a fibroid grow. Fibroids usually cease growing and even retreat in size with menopause. Why? Because the hormone levels drop so dramatically. The estrogen levels, there isn't that excessive stimulation. But we don't want that to be the cure. We want you to get a hold of topical progesterone when the PMS comes on, and you can help prevent fibroids. There we go. Carolyn, do you have another question for me? There is another question here, and it is, so would you say that maybe by increasing her hormones would be helpful estrogen too? Well, the question was around fibroids, and the signal about that is actually get progesterone and apply it liberally and see if you can quiet down cramps and breast tenderness. Now, some women in the perimenopause also need estrogen, and you'll know that if you're also getting periodic hot flashes and other symptoms that we list in our book, that Carolyn has a free PDF copy of it that you can download right off of the ins and outs of menopause. But that's a whole other subject. When you're saying hormones, let's think about estrogen. Well, let's think about estrogen when there's actual estrogen deficiency symptoms, and that can occur long before your periods cease, thus being in the perimenopause. And then what about testosterone and DHEA? They're also produced out of the ovary. There's more testosterone produced in the woman than there is her most potent estrogen, estradiol. And you can get symptoms of testosterone deficiency, and there are women that we treat with testosterone right out of the gate. All women need testosterone eventually, but some women even in their 40s will be giving testosterone even when they are having periods, because there's symptoms of testosterone deficiency, and they're pretty clear cut. And all of these, again, are listed in our book, Happy Healthy Hormones, which you can download a no-charge PDF version of from Carolyn's Facebook page, Ins and Outs of Menopause. And here's Carolyn's next question. Let's see here. Does a lack of progesterone contribute to the horrible migraines so many women get in perimenopause? Well, we classically think of women who have migraines that they didn't have earlier in their life when they were regularly menstruating, or even when they still are regularly menstruating, but they're getting migraines all of a sudden in their 30s or 40s. These are named menstrual migraines, and they occur primarily from the major drop in estrogens that occurs mid-cycle or just before the period. Estrogen is not excreted by the ovary in a steady state throughout the whole month. No, it's not like that. During the period, if that's day 1, estrogen starts getting excreted, and by day 12, it peaks high levels, and then it drops. And then it rises again to about 2/3 of its major peak, and then it drops again. So there's 2 vulnerable times during the cycle when estrogen can get too low. It's right after mid-cycle, and it's right before the period, or during the period. Estrogen really can dip. Well, if a woman is not producing the rich amount of estrogen she did when she was young, that decline becomes more significant, and it can trigger a migraine. So when we think of menstrual migraines, I very much think absolutely first of estrogen and replenishing estrogen. Now, there is an interesting thing that progesterone has many effects. And one of its effects, try and grok this one, is it makes estrogen receptor sites more sensitive to estrogen. Go figure. Want to believe in the divine? Study the female menstrual cycle. Progesterone can make estrogen receptor sites more sensitive to the estrogen that a woman produces. That means that some women in their 30s or 40s who are getting these menstrual migraines, if they just take progesterone, they can get increased estrogen effect and thus alleviate the migraines. But if you're getting menstrual migraines, we want to think both of progesterone as an easier and simpler fix if it works. But really, we want to raise the general level of estrogen, so we'll administer biased for any woman with menstrual migraines. There are other causes of migraines. So if they're not classic menstrual migraines, or they don't respond well to hormone replenishment, you'll want to seek someone out who really specializes in diagnosing and treating headaches and migraines. All right. And then here comes Carolyn, again with a follow-up question. When they do get progesterone, they tend to get better. And comment that so many physicians do not know this. Yeah, there's physicians pretty much need to take a special interest in hormones in perimenopause and menopause to know these kind of things. There's only so much training you can cram in to a medical student and intern and resident over the course of 4 years, and cram they do. Woo-hoo! It's quite a piece of work to make it through medical school, internship, and residencies. And we don't learn everything because the body of knowledge related to medicine is way too huge. So some physicians don't know the details about hormones. And so a lot of physicians don't know that menstrual migraines occasionally can be alleviated by giving progesterone alone. But you don't stop there. If progesterone doesn't do it, you certainly bring in biest or estrogens. All right. I can almost hear Carolyn there because she puts in caps. Oh my, yes. Do you have the next question, Carolyn? It's not as much fun when I don't see you. Is there any way to reboot that computer and get it so I can see you? Okay, the top question. Carolyn's trying to direct me. I'm sorry, Carolyn, I don't see that. So here's a question that Carolyn just sent me by email. Just bear with me for a moment. Is it true if we take a solid pill of any of the hormones that due to the first pass through the liver, we might only get a fraction of that pill, like maybe 10% or 20% of what was actually written for us? Yes, that is true. Here's how it works. When you apply estrogen or testosterone to the skin, it absorbs right into the bloodstream. And here comes Carolyn Shapiro.
Trying.
Here you are.
I'm here?
Welcome.
Oh my God, that's me.
I just read the next question, so I'm going to answer it. It was the one about taking hormones by mouth. And welcome. Good to see you.
Oh my God, it's really good to sit. It's so hard to sit here nodding my head at myself to all your fabulous answers. So very quickly, welcome, Dr. R. Thank you for our ad lib. That was wonderful. It's good to know you. So we can do this. Welcome, everybody. And again, thank you for the answers to those questions. I don't know.
Pick up where I just left off.
Yeah, please.
And it's around taking hormones orally. Well, for one thing, I would encourage all of our listeners to, when you think of estrogen, don't take it orally. And when you think of testosterone, don't take it orally. Now, having said that, a lot of oral estrogen has been prescribed over the course of time, and that's and the women who received that oral estrogen, the vast majority of them did terrific and far better than those who did not receive estrogen. For example, even Premarin and Prempro derived from horse urine. The women who were on Premarin and Prempro, and there was millions and millions of them, they did so much better than their counterparts. So I say I'm going to recommend that you don't take estrogens orally, at the same time respecting and honoring the great good that was done. However, over time, more was learned about hormones than taking them orally. A lot more was learned. For one thing, we learned with the advent of birth control pills that there was a certain number of women that were getting thrombophlebitis, blood clots in their legs, and occasionally a pulmonary embolus when that blood clot broke loose and went to the lungs. And what we learned was the cause of that was the oral estrogens. So here's what happens when you take estrogen orally, or any fat-soluble hormone or medication or whatever you're thinking of when you take it orally.
May I ask something quickly? What does fat-soluble mean? Does that mean it dissolves in fat, doesn't dissolve in fat?
Good question. Almost any substance that you can think of can be taken up into solution, otherwise known as dissolving. So for example, if you have a glass of water and you sprinkle some salt in it, very quickly those salt crystals, which are solid, are going to disappear. And really what they're doing is they're dissolving. Excuse me. they're going up into solution. Well, salt dissolves beautifully in water, but butter does not dissolve in water. You put a hunk of butter into a glass of water, it's going to float.
Ew.
Fat does not dissolve from water, or anything that is fatty like is not dissolved in water. And hormones, steroid hormones, those that come out of the ovary and the testicles and some out of the adrenals, they don't dissolve in water at all. And they require special handling. And when you're wanting to administer a hormone, for example, to the skin, you can't just put the hormone right on the skin. These hormones are eventually are produced in powder form, so you can't put powder on the skin. So what they do is they take the hormone powder and they dissolve it in something that's capable of dissolving fat. So if you put butter into alcohol, you could get it to dissolve. Or you put steroid hormones into alcohol, you could get it to dissolve. In fact, you need strong solvents to dissolve poorly soluble steroid hormones.
Hence fillers?
No,
No?
fillers fillers are, you put something in a capsule, and because you're putting a tiny amount of powder in a capsule, you need something to fill up the capsule so it doesn't look weird. So fillers, that's something else, and there's all
Okay.
kinds of fillers that are made, but that's different.
Uh-oh.
And the so going back to estrogen, we learned over time that, well, maybe it's a good idea to not administer estrogen by mouth because there's going to be a small percentage of women that are going to get blood clots from it. Yes, it was small, but you don't want to be that woman.
Mm.
So the optimal way to apply estrogen is to the skin in a topical base. We use organic oils. We love organic oils. There's creams and gels that are also being used. Estrogen applied to the skin, that's state of the art. If I didn't have topical hormones, yes, I would administer estrogen orally. I'd recommend that women take it orally. Now, what happens when you take something orally? Well, you swallow the oral hormone, estrogen or Premarin or whatever it is, and it goes to your small intestine right after the stomach. And from that small intestine, it travels directly to the liver. And the liver sees that much hormone, and it automatically does what it does. It starts converting the hormone into something called metabolites.
Yes.
And the liver in a young, healthy person is so vigorous that before any estrogen gets to go to the general body circulation, the liver metabolizes about 80 or 90% of it. So only what you administer as an estrogen orally, 80 to 90% of it goes right to the liver, gets immediately metabolized, and about 10% of it, 20% of it makes it on through the liver without being affected. So you've got to get your doses a little richer if you're going to administer a hormone orally. And it's the amount of estrogen we think is part of what provokes the trouble that we can get into with estrogens. And the trouble we can get into with estrogen is excessive amounts of estrogen being metabolized can cause the liver to produce proteins that enhance coagulation and enhance inflammation.
Ooh.
Therefore, we recommend best case is, state of the art is, don't do that.
Can I quote you?
Yes. when you when you apply it to the skin, that doesn't happen because it goes right into the bloodstream when you apply it to the skin, it circulates to the whole body, and then it's picked up from the liver after it's done all of its good stuff when it's circulated to the whole body. It doesn't go directly to the liver when you apply it to your skin, gets in your bloodstream, circulates to the whole body, and then gets picked up by the liver. That's estrogen. Testosterone is not safe to administer orally. We always want to give it topically. So that's the answer to that question, I hope.
Yeah, and the takeaway is don't do that.
Don't do that.
Don't do that. Love it. I tell Daryl that he's going to use it. It's an excellent answer, and I know that there's a lot of confusion around that because women feel like if they take something orally, they're only getting maybe 10% of whatever it is they're taking, and then they get really freaked out. So, thank you very much for explaining that. Um, okay, this is a question that I like, and I'm hoping you'll like it. Very confusing still to me. How does a hormone know how to go down one pathway or the other? Example, like testosterone turning into estrogen. Um, and there are three estrogens. So, how do any of these estrogens know how to go to wherever they need to go? Or progesterone knows how it needs to go via what path? How do they know these things? Is that the divine? Or is that medical school?
That is the very best explanation possible. I mean, how does oxygen know how to go to every cell and combine with the breakdown products of the food that you eat? How does your
Well,
heart
like,
your heart know how to pump? How do
right?
your lungs know
Yeah,
how to breathe? How do your eyes know how to see? It's that deep and that profound.
I know.
What you're referring to is that your body takes the food you eat and produces hundreds and hundreds and hundreds of biochemicals from the food you eat. And one of the things it produces is hormones, the most powerful biochemicals in your body. And it actually takes the cholesterol that's in your diet and transforms that cholesterol into many of the hormones, not all of them, but a lot of the ones, all of them that come out of the ovary, and several of them that come out of the adrenal. It takes that cholesterol. So why don't you just eat butter and you'll be fine in menopause? Well, it doesn't work that simply. And how does it do that? It takes the cholesterol and it converts it to something chemically. I mean, how it does that first step of converting cholesterol and winding up with pregnenolone, it's staggering. It's got to move molecules around and atoms around certain molecules. It's you can't explain that how it knows how to do that. And then it takes that pregnenolone and it converts it into progesterone. And it takes that progesterone, and depending what pathway it goes down, it can turn it into testosterone. It can turn it into, and it can take that testosterone that it makes and take another step and turn the testosterone into estrogen, into estradiol. Huh? You mean a woman's estradiol derives from the hormone called testosterone? Yeah, biochemically, a lot of the estrogens derive from converting testosterone to estradiol. You can go another way to do it as well by converting DHEA to estrone. But yeah, these biochemical roadmaps or pathways are fun. That's one of the reasons I got into this work, because I was so fascinated by those conversions. But you're asking, how in the world does that take place? You got to talk to the divine to get the answer to that. This is way beyond my pay grade.
Hang on, he's in the other room. Let me ask. It's fascinating.
There's some questions that have come up in the chat that I think are worth addressing.
Please.
What about micronized progesterone? Well, micronized is just making progesterone into a small enough particle that it absorbs better. And this is done by pharmaceutical manufacturers, and it's a great process. And we highly recommend that the progesterone you use is micronized. And I'm not aware that there is a non-micronized progesterone on the market. I haven't seen it. Most all the progesterone that is being compounded is micronized, means the particle size is made small enough to be better manageable when you put it in the creams and gels and capsules. Um, Once hormones are balanced, will fibroid ever leave? They can. One thing you can do is you can stabilize them by getting enough balancing progesterone. That means you really get rich with that progesterone. Any woman who has a fibroid, we'll start her on a lowish dose of progesterone, and we'll gradually increase that dose. And what are we trying to do? What's the absolute maximum that that woman can take? Progesterone is so calming, and we suggest that a woman take that progesterone at night, that if she takes too much progesterone at night, she's going to be too calm when she wakes up in the morning. Otherwise known as she's going to feel like she has a hangover from taking an overdose of a sleeping pill. So that's what happens when you take too much progesterone. Any woman who has a fibroid, we're going to keep jacking that progesterone dose up until she wakes up groggy. And then, of course, we'll back down. We don't need her to be on an excessive dose. What's the limit there? Well, I was down in teaching for A4M this weekend, and I heard the all-time record from a dear, dear colleague of me, Dr. Philomena Trindade, a world expert in a lot of things. And she was telling me about administering 600 milligrams of progesterone to someone. And the woman who took that 600 milligrams of oral progesterone, that's about 3 times higher than the higher commercial doses produced. The highest commercial dose is 200 milligrams of prometrium. This is 3 times that. And the woman that she administered it to felt great. She slept like she hadn't slept in a long time and felt just tremendous. Now, I don't want that term 600 to be sticking in anyone's mind, but I want to give you an idea how high you can go. And you got fibroids, you want to go high. You want to get the absolute maximum dose. 300 milligrams would be more of an upper limit that I used to thinking of. And, you know, the main thing is you take any individual woman with a fibroid, you start her lowish and you gradually increase her until she wakes up the next morning with an overdose. And you can even add some progesterone during the day, providing you don't make her groggy, and especially if it improves her mood. So what we're talking about is, can we stop the growth of that fibroid? Can we even get it to shrink? Stabilizing the growth of fibroid is a great achievement. And then what cures fibroids? Well, if a woman goes into menopause and her hormone levels drop, i.e. her estrogen levels drop, the fibroid's going to stop growing. So let's see. There was another question here. But let's go on to the questions that you had. Okay, Carolyn?
Well, the ones that I had, I actually went ahead and I asked, and so I'm relying really on the questions that are coming up on the chat. There are 2 here.
Let's ask one about the thyroid and bias.
Yeah, can you ask that? Because I can't see it.
Yeah.
Here, thank you.
It has been told to me that until I fix my thyroid, my bias won't stop my hot flashes. Well, I'm going to agree and not agree. The suggestion that it's important to address thyroid issues is a fabulous suggestion.
Biggie.
But I don't agree. So many women, even if we don't address their thyroid, we can address their hot flashes, and those hot flashes are going to go away by getting the estrogen and progesterone and testosterone and DHEA balanced, absolutely, and replenished. But what's being implied here is that thyroid matters, and it does. And you know, midlife, not having adequate or a fully robust level of thyroid that we had when we were younger is extremely common. It's epidemic, actually. And even if your quote thyroid blood tests are quote normal, no, we use a finer tuning reference range for this. And in midlife, you will not see levels of free T3, free T4, or TSH that you see in 20-year-olds. Why did that happen?
Hmm.
Because of the excessive demands of the fight or flight response. If you have an exaggerated response to the stresses of life, internal and external, you're going to call on your most powerful biochemicals to help you in a primitive state fight or flee.
Yeah,
You
survive.
need, and you need the strongest hormones that you got happening, and you recruit them all. And that includes thyroid. You know, the leading hormones are adrenaline and cortisol, but thyroid is going to be recruited. So is estrogen, so is testosterone. These are all energizing,
Right,
and
and it happens fast, fast.
your body knows how to call them forth. Well, you keep calling forth excessive thyroid hormone year after year after year, and your thyroid can't keep up with it. So midlife, there's a lot of folks coming in there with functional hypothyroidism. That means their thyroid levels don't show disease, but they do show under closer scrutiny evidence of not being enough to do the job. So I do agree with the suggestion that pay attention to that thyroid in midlife as well. We have, for our professionals, we have a 12-hour online training program. It's in 84 segments, and the longest segment of all is on thyroid because we know our providers need to be expert in thyroid as well. So, but many a hot flash is stopped by replenishing bias and progesterone.
Um, just on that note, I want to just ask a question just off my own mind. Is Have you heard of women like going through the day, they're taking bias, they're fine, everything is great during the day, but those hot flashes seem to happen in the middle of the night? Is there a reason for that?
I don't know what that reason is. You certainly are mentioning something that is ever so common. Why would they tend to happen in the middle of the night? Well, a lot of things go bang in the night. For one thing, a certain level of stress and de stressing can take place in the middle of the night, in the sense that when the repression brakes are off, and you go to sleep and you're no longer consciously repressing uncomfortable feelings, they can emerge royally. And it's why so many of us have uncomfortable dreams slash nightmares. Our brains have a chance to release and deal with issues that we weren't dealing with successfully in the day, or we were suppressing or using something to avoid them. So things go bang in the night in our consciousness and in our emotions. That's the best explanation I've ever come up with, Carolyn, for this common phenomena of women who they'll get warm rushes or some hot flashes during the day. But the other thing is they're very tolerable. Women are strong and they get a hot flash during the day, and okay, big deal, it's menopause. But when you get a hot flash at night, you wind up triggering the biology of the stress response.
That
You get,
saber tooth tiger.
you get an outpouring of adrenaline. You can get a rapid heartbeat. You can get chest pain even from the heart beating so rapidly, otherwise known as palpitations. You can get a racing mind because when you get adrenaline, your mind really knows how to zip and zing, as many college students know from taking an artificial adrenaline to
Right.
be able to pull an all-nighter and study. Boy, does your mind get active. And so, yeah, those hot flashes that occur at night, they're stressful. They throw in that extra added attraction called adrenaline, and you get to stay awake and get energized for as long as it takes your midlife liver to dismantle and metabolize that adrenaline into non-activity. Well, a 20-year-old liver can dismantle adrenaline really quickly, just like you can dismantle coffee really quickly. But a midlife liver doesn't necessarily work at the same pace as a 20-year-old liver. So a woman gets to stay awake for as long as it takes for her liver to metabolize or dismantle the potency of the adrenaline that gets triggered. So they're troublesome in the night. And it's not
Yeah.
only the hot flash, it's what the hot flash triggers as far as the fight or flight response with all the adrenaline that gets poured out there.
It's where that word raucous comes in, which I love because it's so descriptive. And it does tend to happen often in the middle of the night. You're sound asleep and bam, now you're wide awake. And now you're sweating. And now you're not happy.
There's a question here, another question I'd like to address. Do we need to rotate the location in our bodies where we apply estrogen? Or for that matter, any hormone that we're applying to our bodies? Some women do and some women don't. I have one patient, and this is not the common thing. She's been applying bias to her forearms, soft forearms right here, rubbing those forearms together for 23 years, and she still gets great absorption. Whereas another woman, if she keeps on applying the hormone to the forearms in the exact same place she's applying it, you'll get saturation of the skin and the underlying subcutaneous fat, and she'll benefit from switching sites, from rotating sites. And how she'll know is she'll be getting good results from her bias, for example, and alleviate hot flashes, and she keeps rubbing on her forearms, and then after a while, she'll start getting a return of hot flashes. And one of the things to look at in that case is she getting something called dermal fatigue, where
Yeah.
the skin and the subcutaneous fat has gotten oversaturated. So what do? The remedy's not hard. You switch. We recommend that a woman switch from the soft forearms to the back of her shoulders there and rotate back and forth. We recommend that when you're applying topicals that you don't apply them to the same location. Like, for example, we like to have a woman apply her testosterone to a different location than she does her estrogen. And we have her apply her progesterone to a different location. Progesterone will often start with the inner thighs. So some women do need to rotate, and some women need to rotate almost every month or every couple of weeks. It all depends on your individual situation. If we start seeing signs that the hormones that were functioning well are not functioning as well, that'll be the first suggestion. Hey, rotate sites.
It's a
All
good
right.
answer.
For one
Yeah.
more question, because again, I have a hard stop just before the hour.
Okay. Geez Louise. Well, here's one. My doctor said my estrone level is too high, while other estrogens are normal. She told me to take 20 milligrams of DIM supplement daily because it'll bind with some of the estrone and help eliminate it from my body. Uh, what is your feeling about this? Or question number two.
Well, part of why I'm chuckling is I don't have enough information.
Got it.
And one of the best ways, I mean, if a woman, I don't know if this woman is premenopausal and so she's still having periods, or she's in menopause and she's being treated with hormones. So there's too much missing information here. But if she's being treated with hormones and she does a 24-hour urine, her estrone is going to be present in 2 times plus the amount of estradiol. So I'd have to see the actual numbers that this was derived from. Estrone is more prevalent than estradiol, certainly in a 24-hour urine. DIM is a derivative of the food family that broccoli and cauliflower are in, the brassicas. And there is a folktale that if you take DIM, that you're going to facilitate the biochemical processing of the hormones, and you're going to help straighten out um, what's called metabolization, or the byproducts of the original hormones. You're going to straighten them out and get more of the favorable kind of 2-hydroxy versus the 16 alpha. I've prescribed a lot of DIM, and I can't say that this is a 100% reliable source of being able to really transform how the liver processes the estrogens, for example. But what I do when I'm seeing abnormal processing, like there would be a way excessive amount of estrone, I'd want to know why.
Yeah.
And very often that will lead us down the path of functional medicine to try and understand, is the liver doing as good a job as it could be doing? And if there's a hint that the liver is not doing as good a job as it could be doing, we ask why. There's going to be causes for that. And one of the causes can be the intestinal tract, the gut, because the liver is downstream from the gut biologically. That means what's in the gut, some of it goes into the liver. And so if you've got a dysbiosis, an unbalance of the normal healthy bacterial population, which amounts to about 3.5 pounds of bacteria, this is a significant thing in our bodies. If you got an unbalance there, and some of these bacteria, for example, and yeast and stuff, they're living creatures. So they're doing their own biochemistry, and they've got their own excretions that are coming from that biochemistry. So either the presence of the bacteria or how they're handling your biochemicals or how they're producing their own, they can go to the liver and they can make it hard for the liver. So what am I talking about here? A trail that every functional medicine provider, all the way from medical doctor, an osteopathic doctor, through nurse practitioners and health coaches and PAs, that take on the time and have the desire to get some extensive training in functional medicine. Every one of us meet up with the intestinal tract and its effect on the liver, among other things. So when I see imbalances and it doesn't respond immediately to DIM, as is a tale that is told,
The folk tale?
the folk tale that's told, I'm sure I'll get a lot of flack from my colleagues around that one if anyone tuned in there. I say, take a look at that liver. And when you take a look at the liver, invariably you're going to be led to the intestinal tract. Carolyn, I want to sign off.
Okay, well, we managed to get through this. It's amazing that we did, but we did. So thank you, Dr. Rosensweet, always so much. Thank you, everyone, for being here. Got your questions, got more questions. We'll see you in 2 weeks. Have a great time, and let's all try and be well and healthy and happy and positive and of kindness and of love. We'll talk to you later.
Bye-bye, Carolyn.
Bye.